Okay, so welcome again. Thank you for joining us for today's webinar, Understanding Breast Cancer Recurrence Part 2, the Clinical Perspective. I'm Rebecca Armstrong, the Director of Patient Education and Engagement with the Canadian Breast Cancer Network. This session, as always, is being recorded and will be available on our website for anyone who may want to rewatch it or if you've missed it. And I'll send out a link to the recording once it's available. And you'll also find previously recorded webinars that address a variety of different topics on our website. I'd like to extend our sincere appreciation to our sponsors for the session today, who provided unrestricted educational grants. Novartis, our gold level sponsor, Pfizer and Gilead, our silver level sponsors, and Bayer, Tercera, AstraZeneca, and Lilly Canada, our bronze level sponsors. The format for today's session will be a presentation by our expert speaker, and then followed by a question and answer period. So please feel free to submit your questions using the Q&A function that you should be able to find at the bottom of your screen. And our speaker today will do her best to answer your questions, but please note that she may not be able to speak specifically to individual situations without having a complete medical history. I'd now like to welcome our host for the session, Kathy Amendolia, Chair of the Board of the Canadian Breast Cancer Network.
Thank you, Rebecca, and welcome again, everyone. Thank you for joining us today. I'm pleased to welcome and introduce our expert speaker, Dr. Karen Gelmon, who is a professor of medicine at the University of BC and a medical oncologist at BC Cancer in Vancouver. She also serves as a member of the Canadian Breast Cancer Medical Advisory Board. Dr. Gelmon, great to see you, and thank you for being here today with us.
Nice to see you, Kathy, and Jennifer and everybody. And thank you, everybody who has joined this webinar. So should I just get started or any?
Yep, go ahead and share your screen.
Okay, we'll do that. Okay, so what I was asked to speak about today is about estimating the risk of breast cancer recurrence and follow-up of early breast cancer. As you heard, I'm happy to answer questions after. I can't really answer a lot of questions often about people's individual experiences in a total way, but I'm happy to take any of your questions. These are my conflicts. So when we talk about clinical care, we talk about various treatment algorithms. In early cancer, we look at risk versus response, and we'll talk about that a bit more. Basically, early cancer is considered curative. We never can make a guarantee, but it's considered curative. And just to remind you that early diagnosis is really important. Mammograms do make a difference. They diagnose cancers earlier. Breast exam, if you notice a change, it doesn't have to be a lump, just a change, does make a difference. It makes a difference to diagnose cancers earlier. Advanced cancer is when cancer is away from the local area. We also call it metastatic. Advanced cancer is when, for example, a breast cancer is in the bones or the liver or the lungs or other places, or a bowel cancer is in the liver. With advanced cancer, our goals are to improve symptoms, to improve good quality survival, and to improve quality of life. And at a certain point, there's supportive care, which is really end of life care. Now, the thing that confuses lots of people, and it's not just people who don't have medical knowledge, lots of people are confused by this. It's the properties of cancer. Cancers can grow, whereas, your eye forms when you're a baby and your eye stays that way. Cancers grow, whereas your skin, when you get a cut, can heal, but usually it heals quite flat. Cancers can keep growing, and that ability to grow with unrestricted growth is the main property of a cancer, the fact that it can keep growing. The second important property about a cancer is that cancers can travel. We also call that metastasize. And cancers can travel through the blood and or lymphatic system. Now, many of you on this already know it, so I'm sorry if this is elementary for some of you, but it's always important that we go through this. So when somebody has a prostate cancer and then it's in their bones, it's still prostate cancer. It traveled through the blood or through the lymphatic system, which is another system that goes through our body. When someone has breast cancer and then it's in their bones, they don't have breast and bone cancer usually. Rarely that could happen. Usually what it is it's breast cancer that's traveled to the bones. And how do we know this? First of all, we know that cancers can travel, but secondly, if we biopsy that bone area and a pathologist looks at it under the microscope, it doesn't look like bones, it looks like breast cancer. Pathologists are able to tell what is what. Excuse me, not 100% of the time, but most of the time they can say this is consistent with breast cancer. Now, cancers have what we call both prognostic and predictive features. A prognostic feature is a feature that predicts the behavior of the cancer. A prognostic feature might be that it's very low grade, that means it's not going to grow very fast, and then it's not going to likely travel. Or it might be very high grade, which might mean that it is growing faster and may travel more. Prognostic factors can be size, can be other things. I'm going to talk more about that. But a prognostic factor helps us predict the behavior of the cancer. Sorry, I've got this terrible cold. A predictive factor predicts the response. Some factors can be both prognostic and predictive. But a predictive factor tells us, will it respond to a certain treatment or not? So this is a breast cancer classification, and you don't have to remember this. I just put this in for really a historical context. When we look under the microscope, we get what we call histopathological types. In triple negative, we might get medullary, adenocystic, metaplastic. The most common is an infiltrating ductal carcinoma, not otherwise specified, also known as a mammary carcinoma. And then there's these cancers that are sensitive to estrogens called lobular cancer, tubular cancer, mucinous cancer. These make up, the middle ones make up about 65% of cancers. Lobular make up about 15%. And lobular have been known about for a long, long time. We started to look at cancers in another way, to stain them, to see if they had receptors. Receptors are on the outside of the cell, and they're like doorways. So they're like doorways that open up to let something in to make it grow. The most common receptors are estrogen receptors. Estrogen receptors respond to the estrogen you have in your body, and whether you're pre or postmenopausal or a man, you have estrogens in your body. And the estrogens stimulate an estrogen positive cancer to grow. When we started looking at these, we found out that there were estrogen positive cancers. These both are estrogen positive, and estrogen negative cancers, where estrogen doesn't make the cancer grow. In the late 80s, we also recognized something called HER2. HER2 is a gene that in about 15% of breast cancers, there's too much of it, it's overexpressed. So then we started looking at estrogen positive, HER2 negative, estrogen positive, HER2 positive, estrogen negative, HER2 positive, and estrogen negative and HER2 negative. And these have been called triple negative because they're estrogen negative, progesterone negative, HER2 negative. It's not a great term, but these are called triple negative. In 2000, there was a study done where they started calling them by different names. Luminal A were these low-grade estrogen positive, luminal B, the higher grade estrogen positive. HER2 related were those that didn't have estrogen but were HER2 related, and basal, Leichter, Cloud, and Low were the triple negative. And then subsequently, we started sequencing the genes. Now, sequencing is looking at the DNA or RNA in the gene. And what we found out when we started sequencing the gene by whole gene sequencing was that these luminal A, these estrogen, these slow growing cancers didn't have a lot of mutations, didn't have a lot of changes. Their DNA is very quiet. As you can see by this circus plot, it's very quiet. But as you go up to triple negative, you can see more and more disarray. So this is basically the clean house, and this is basically the chaotic, more dysfunctional house. And basically, that's how these cancers often, but not always, behave. Now, we have all those fancy classifications, but when you're sitting across from your healthcare provider in the clinic, basically, they're looking at all breast cancers. They're looking at 65 to 75% are hormone positive. They're looking at 15 to 20% are HER2 positive and 15% triple negative. So we have fancy classifications, but we often just use these simple classifications. Oh, your cancer is estrogen positive. Oh, your cancer is triple negative. Oh, your cancer is HER2 positive and hormone positive. So this is what we often use in the clinic, but those other classifications help us. When we're talking about an early cancer, our treatment requires estimating the risk of relapse and the response to treatment to decide how to treat a person. We look at prognostic features, and you remember those are inherent to the cancer, and we look at predictive factors to figure out how to treat it. So the prognostic factors help us understand the risk of relapse. Now, why will a cancer relapse? A cancer will relapse because it's made of millions of cells, and by the time we diagnose most cancers, there's a risk that those cancers could have traveled from the primary. I don't know how many of you remember your logs from math, but a 1 centimeter tumor has about 10 to the ninth cells. So if you take 10 plus 9 zeros, that's how many cells are in a 1 centimeter tumor. You can imagine that a 1 centimeter tumor has a much less risk of relapsing than a 5 centimeter tumor that's going to be 5 times as big. So we try to figure out what's the risk of relapse. What's the risk that before we did surgery, before we diagnosed that cancer, some cells have left. We talk about disease-free survival and overall survival, how to decrease that risk, and how aggressive is the cancer. When we talk about cancers, I like to talk about biology and architecture. Biology is what's the grade? Are these slow growing cells, fast growing cells, intermediate cells? Are they estrogen positive or estrogen negative? That's the biology. The architecture is really how much is there? It's like, is that apartment building 6 stories or 12 stories? So how big is the cancer, and is it in the lymph nodes? The first place cancer usually likes to travel is to the lymph nodes, often to the lymph nodes in your armpit. So how big is the cancer? Is it in the lymph nodes? Those are the questions. And those put together are prognostic features to determine the risk of relapse. The predictive features are, well, what's it going to respond to? Is it endocrine positive? Will it respond to hormone treatments? Is it going to respond to chemotherapy? Low-grade cancers often don't, whereas high-grade cancers do. Does it have HER2? Will it respond to HER2 treatment? Should it respond to immunotherapy? Some triple negatives and some positives respond. We know that cancers that have BRCA1 or 2 mutations respond to PARP inhibitors. And what about other treatments? So we put this all together to estimate first the risk of the cancer coming back, and secondly, the response to treatment. In early breast cancer, we've changed how we're treating. And why have we changed? We've changed over the years because we realize that we are better at estimating the risk of relapse, and everyone doesn't need treatment. And we also want to limit toxicity. We want to give the best treatments for the most appropriate cancers. So when we first started treating early breast cancer, almost everyone got chemo. If their tumor was 2 centimeters or in the lymph nodes, everyone got chemo. And we now know that might not be the right way to go. So we're decreasing use of chemo, particularly in the ER positives. Some ER positives, if they have nodes positive or a high grade or a high enough risk of relapse, we're going to give chemo. But in a lot of ER positives, we don't give chemo. We're using genomic tests. These are tests that test the tumor not your genes in your body you've inherited from your mothers and fathers, but your genes in your tumor to determine is this a high-risk cancer or not. The most common one used in Canada, that's paid for by most of the provinces, that's sent to a lab in California and costs about $5,000, $4,500, $5,000, is called the oncotype. And what the oncotype is used for is estrogen receptor positive low-grade cancer, or usually low-grade cancers, to determine would chemo be of benefit. We get a score and we use that score. Prosigna and Mammoprint are other similar tests. We're not using as much of drugs called anthracyclines now. Why? Because we know they can be hard on the heart and also they can cause leukemia sometimes, rarely, but sometimes. We do use them in some situations, but not in all situations. We're using more chemo before surgery. So in persons who have HER2 positive cancers, persons with triple negative cancers, or persons with large cancers, we give the chemo neoadjuvantly, we call it, before. We also, if we've given neoadjuvant chemo and there's still some disease after surgery, we use post-adjuvant treatment. We're using germline testing to determine who has a BRCA mutation because we know they may benefit from specific surgical techniques and also from PARP inhibitors. And we're very keen to use more supportive care. We've been doing exercise trials for years. This year, there was exciting news from the CCTG that a Canadian-led trial in colorectal cancer of exercise, supervised exercise, decreased the risk of recurrence of disease. That was exciting. We already knew that exercises decreased anxiety in women with breast cancer. So exercise is important. Now, who do we treat? If somebody's got a very, very tiny cancer, node negative, T1A is about 1 millimeter to 5 millimeters or 0.1 to 0.5 centimeters. Generally, we wouldn't give chemo because the risk of the chemo outweighs the benefit. This cancer would have a very, very small risk of relapsing. So we probably wouldn't give chemo, but we might give endocrine therapy. If it's slightly bigger, we might even give anti-HER2 therapy if it was HER2 positive, but we probably wouldn't give chemo unless it was triple negative. When you're getting a bit bigger, we're going to give more therapy. When it's getting to be a 2 centimeter or greater tumor, we might give neoadjuvant if it's triple negative or HER2 positive. And when we're getting to be node positive, we might give chemo, neoadjuvant, other hormones, HER2, all of these. This is basically what I talked about with architecture. As the cancer gets bigger, we think the risks get bigger. Now, before we go on, I want to talk a bit about the fact that there are three kinds of recurrence. And this is also something that confuses people. There's local recurrence. You have a cancer in your breast. What's the risk of it coming back in the breast? To do that, we give surgery and we try to get clear margins. So that's like taking all of the black part out of an apple and being left with no black part. Clear margins. If the tumor is a good size, sometimes if it's 5 millimeters, we don't, but otherwise we often give radiation to decrease the chance of local recurrence. And we also know that endocrine therapy, aromatase inhibitors, hormone therapy, tamoxifen, can also decrease the risk of local therapy. Many patients come and say, I saw the surgeon, she said she got it all. And we can say, yeah, she did a great job. She did great surgery. It looks like she got it all. But we know that cancers are made of millions of cells. She might have gotten it all locally, but we're still going to be doing some radiation or hormone therapy. But the fact she got it all in the breast doesn't change a couple other recurrences. The other kind of recurrence is regional. What's regional recurrence? Coming back in the lymph nodes or the other breast. Somebody who doesn't have a mutation of their genes has about a 0.5% per year risk of getting cancer in the other breast. So if you're 70 years old and you get a cancer, you've got, let's say, 30 years to live till you're 100. You have about a 15% chance of getting a cancer in the other breast. If you take hormone therapy, it goes down to about a 7%. So you can see if you're 30 years old and you might have 70 years to live, your risk is higher, but again, you're going to get followed. The third type of relapse is distant. And this is what I've been talking about when I talk about cancer coming back in the bones or the liver or the lungs. This is distant recurrence. And distant recurrence is based, as I said, on the architecture, the size, the number of nodes, and on the biology. Some cancers have a higher risk of coming back distantly than others. When we give endocrine therapy, chemotherapy, anti-HER2 therapy, immunotherapy, what we're really trying to do is decrease distant relapse. Up till now, distant relapse has generally been thought of as not being curable. Years ago, there was a study from MD Anderson in Texas that suggested about 5% of distant relapses were curable. In my practice, I've had a handful of people where I know they've been cured, and it's great and gratifying. But generally, we haven't been able to cure. We think we're now coming to the era where, with better treatments, with better ability to get little disease, we may be able to cure. But it's coming, it's not here yet. And it won't be for everyone, it'll be a stepwise process, but it's exciting. Now, what about a presentation? With mammography in a large percentage of the population, so go for your mammograms, about 50% of patients are diagnosed with tumors up to 2 centimeters that aren't in lymph nodes. About another 45% are diagnosed with tumors that are still what we call early. So they're bigger tumors are in the lymph nodes, but still considered curable. And about 5% of tumors are diagnosed when it's already spread and is stage 4. With PET scanning, we're diagnosing a little bit more of these. This is going up a bit closer to 10, but we don't know if those asymptomatic stage 4s are the same as symptomatic. So what we want to do is we want to diagnose people at stage 1 or stage 2 if we can. We are diagnosing about 80% of people. We want to diagnose more. Why is this important? I mentioned biology, but we know nodal status is important. This is data that's from the Oxford Overview, where they collect data from around the world. And what you can see is that if you've got a tumor, this is old data, our statistics are better now, but this is worth showing, that if you've got a tumor that's less than 2 centimeters and not in the nodes, at 20 years, you'll have about a 20% risk of relapse. Now, that's lower with most of our new treatments, so don't get scared. But in this old data, if you had a bigger tumor, a tumor 2 to 5 centimeters with more than 4 nodes positive, it was almost a 50% risk of relapsing. That's why we want to diagnose smaller tumors without being in lymph nodes. We also know that breast cancer recurrence is confusing. A fellow of mine who was from Brazil did this study. Basically, what we wanted to see is, when does breast cancer recur? This was an old cohort before we gave anti-HER2 therapy, before we gave as much hormone therapy like aromatase inhibitors, before we gave as much chemo to triple negative. And what it shows is that these are the estrogen receptor positive, HER2 negative, that they relapsed, little peak at 1 year, but they kept relapsing out at 8 years. What you can see is the estrogen receptor negative ones and the HER2 positives relapsed early, and both the estrogen receptor HER2 negative and the estrogen receptor negative HER2 positive, if you hadn't relapsed at 5 years, your risk of relapse was low. We did a more recent cohort after we'd started giving Herceptin and other things, after we were giving more chemo, after we were giving aromatase. And what you can see is fewer persons were relapsing, but the curves look similar. So what we know is that estrogen receptor positive cancers can relapse over a long period of time. That's not very many that are doing it, but they can. Whereas triple negative cancers that are ER negative or ER negative HER2 positive, if they haven't relapsed in 4 to 5 years, they're not going to relapse distantly. So we've made improvements, but we need to make more improvements. One question is, does age affect outcomes? This is work that my colleague Emily Jackson did with me when she was a fellow. She's now a staff person in Vancouver. This pink line is 80-year-olds. This blue line is less than 35. This is persons who die of breast cancer. And you can see that the 80-year-olds and the 35-year-olds die more frequently, often because 35-year-olds, it's diagnosed late or it's a more aggressive cancer. This is overall survival. What does that mean? That means you could have died of anything. And of course, the 80 plus are dying of other things, so their survival's the worst. But you can see that the 35-year-olds and less do die of breast cancer, but they don't die of other things. This line is the 70 to 79-year-olds. What does this graph tell us? It tells us we have to do better with the 35-year-olds and younger. We have to get them up to this. Many of these 80-year-olds don't want treatment, and that's their choice. And I often think, we just have to support them in what they want. And, they're making educated decisions usually on what they want to do. So let's go back to this. I talked about the early breast cancer. How do we decrease the risk of relapse? By adjuvant therapy to decrease risk of relapse. Adjuvant is just as well as, it's like the icing on the cake. Adjuvant therapy can be radiation after surgery, it can be hormone therapy, it can be chemotherapy, it can be anti-HER2 therapy, it can be immunotherapy. And this is a summary of the neoadjuvant and adjuvant treatment we're using these days. So for triple negatives, for all except those very tiny ones, as I said, we would give chemo. If their tumor is more than 2 centimeters or in the nodes, or sometimes even just more than 1.5 centimeters, we would add immunotherapy, a drug called Pembro, because it's been shown to decrease relapse. And if they've got a BRCA mutation, we'd add a PARP inhibitor, a drug called olaparib. And with these things, we are really, really improving the outcomes for people with triple negative. Fewer and fewer are relapsing. We have to improve more our treatment of advanced disease, but we're really improving our early disease. For HER2 positive, whether they're ER negative or positive, we give chemo plus an anti-HER2 unless they're on that really tiny tumor of less than 5 millimeters. If they're ER positive, we'll give endocrine therapy as well. If they're ER positive and HER2 negative, we do prognostic genomic factors often. So we'll often do a recurrence score. In ER positive, HER2 negative, endocrine therapy with tamoxifen, letrozole, exemestane, and anastrozole, that's our mainstay of treatment. And we give chemo if we need to. And if they're hormone or mutation positive, we'll give PARP. And we might give a CDK4/6 inhibitor now as well. Sorry, I thought that was in this slide. It's not. But a CDK4/6 inhibitor if they're high enough of risk. So we'll give Verzinia, or we'll give ribociclib or abemaciclib. With all of these, if they're postmenopausal and at high enough risk, we often give zoledronic acid or denosumab, a bone-modifying agent, because that's been shown to decrease. With these strategies, we're decreasing the risk of the cancer coming back. We're decreasing the number of women and men who will get metastatic advanced cancer. Now, I've just got a few more minutes. I'm going to just quickly go through how do we define premenopausal in young women? Older studies say less than 50 or less than 55, but studies have also looked at less than 40 and less than 35. So in our treatment, we look at whether they're menopausal or not, less than 50. But we know that less than 35 have a bit of a worse outcome. Defining menopause is not just by one simple blood test. We all know your period can stop. You haven't had it for 4 months. You get on an airplane in white pants and you get your period. So we need to do more than one blood test. And treatment-induced menopause, when we put people into menopause with chemo, it may be transient or permanent. So if your periods stop with chemo, it doesn't mean that they'll be stopped forever. For premenopausal women, low risk, we give just hormones, no chemo. Intermediate risk, lower grade but larger tumor or node positive, we'll do the recurrence score. We might give chemo, we might give a CDK4/6, we'll give hormone therapy, and we might give a PARP. And we might give more than 5 years of hormone therapy. And in high risk, larger tumors, node positive, grade 3 younger, we'll give chemo, plus we'll give ovarian suppression, plus an aromatase inhibitor, a CDK4/6, a PARP, and extended adjuvant. In postmenopausal, it's very similar. In low risk, hormone therapy only. In intermediate risk, we'll do our assessment with our recurrence score and give chemo if it's high risk, possibly a CDK4/6, possibly a PARP, plus a bisphosphonate. And in higher risk, we'll give with larger tumors, we'll give potentially chemo plus a bisphosphonate plus a CDK and extended. So it's very similar. One of the differences is ovarian suppression, but oncotype is often used to determine treatment. Do we give more than 5 years? It does decreases your risk on distant disease and contralateral, and every patient needs to be assessed in terms. So larger tumors, more nodes, tolerating the endocrine therapy well, we might give longer. And there are studies of both 7 and 10 years. For low risk patients, 2, 3, 5 years might be enough. There are studies now going on of 2 and 3 years, but 5 years is our amount. And this is about balancing the benefit versus the toxicity. If there's a very low risk, it might be futile to give more treatment. What are the goals of follow-up? The goals are to provide your physical, psychological symptoms and also to, oops, sorry, the goals are to, why can't I go back? The goals are to, Goals are to diagnose curable disease early, to diagnose advanced disease, to enhance compliance because it's hard taking those hormones. We have tricks to try to help you, and to try to promote prevention of bone, sexual, psychological, cardiac health issues, to try to support you. The types of recurrence, as I said, are local in the breast, and it's mammograms and physical examination to do that. So you need your mammograms yearly, indefinitely after you have a breast cancer. Even if you're elderly, keep doing your mammograms yearly. Local regional, it may be surgically curable too. So local recurrence and local regional may be surgically curable. Types of recurrence distant, it may be just a few, and that can be treated with radiation. It should be biopsied to confirm it's still the same. It's usually not curable, but this is changing. Follow-up, we recommend a history and physical every 6 months for 5 years and then annually, mammograms annually. If asymptomatic, no routine blood work, but if any symptoms, they really need to be chased up. And we need to do bone mineral densities because hormone and chemo can be hard on bones. So if there's any symptoms, any physical findings, any concerns, you need to go to the doctor. And if they don't do something, go to your oncologist and get checked. Survivorship issues we know, and are not going to go through this, but we know there's chemo brain, we know there's cardiac, bone health, fertility, sexual, and obviously huge psychological issues. So in summary, risk of recurrence is based on factors such as grade, subtype, ER/PR, positive HER2, how much cancer there is in genomic tests, treatments based on the estimated risk of recurrence, and this has to be made with shared decision-making with the patient. The goals of treatment are to prevent local, contralateral, and distant recurrence. Treatment needs to be individualized to ensure optimal treatment to decrease recurrence with minimal toxicity if possible. And in the future, we hope there are blood tests that, first of all, can determine if someone's at any risk of recurrence and spare potentially lots of people adjuvant treatment, and also maybe to diagnose recurrence earlier and improve outcomes. So I'd like to thank you. I read a article recently that the reason people pay for views is because having a good view decreases your anxiety. So here's a view to decrease anxiety. Thank you for your attention.
Wow, that's all I'm going to say. Thank you so much for that great presentation. I don't know which slide I like the best. They're so clear, they're so easy to follow, and you really put it in a way where you follow it and it's very understandable. Thank you so much, Dr. Gelman. We're going to accept questions, but I'm going to start off by let's have a little discussion here based on what you just presented. So early on, you described the early or types of cancer. What about lymph nodes? Like if you have a microscopic lymph node, is that considered already, what do you call it? Like metastatic? How do you define that? In no
So
matter.
that's a really good question. So, people say, oh, it metastasized the lymph node. Um, Metastasized to the lymph node is, a funny term. It has traveled to the lymph node, and one can in the most sort of clear way say, yes, if it's not in the breast, it's metastasized to the lymph node. We tend not to use metastasized for lymph nodes. We tend to say it's involving the lymph nodes. And we
Mm.
tend to think about metastases as further afield. So it's obviously a question of semantics, and it probably doesn't make that much difference. But generally, when we're talking about metastatic breast cancer or advanced breast cancer, we're talking about it away from the local regional area. There's locally advanced cancer where it is locally in the lymph nodes or a big tumor, but generally we talk about it. Now, it could have gone to the lymph nodes through the lymphatic system, through the lymphatic channels that travel all around our body and go from the breast and drain into the lymph node. Does that help?
That does help, but in your presentation, you treat patients with chemo, with adjuvant therapy if they've gone to the lymph nodes. And
Not
it
always, not
not
always,
always,
not
but
always.
there
No.
are some that you do.
Yeah,
So
some they do. So
you're
what I had said is, when I was first in practice and training, anyone with a lymph node, we gave them chemo. Anyone with a tumor greater than 2 centimeters. Now we don't. So let's say I have a 52-year-old postmenopausal woman who presents with a ER positive, PR positive, HER2 negative cancer that's grade 2 and that's gone to 3 lymph nodes, and I do an oncotype and it's low. I'm going to treat her with only hormone therapy, no chemo. I might give her ribociclib. I will give her radiation. I will give her bisphosphonates, but I might not give her chemo. Likewise, if I've got a 39-year-old woman with a grade 1 tumor that's 1.5 centimeter tumor gone to 1 lymph node, I would probably not give her chemotherapy. I'd give her ovarian suppression and exemestane.
okay. What about family history not in the family of the BRCA gene? Like if you have people that have had colorectal cancer or breast cancer, but you're not defined by the BRCA gene one way or another, how do you treat a patient like that if it still presents in an early stage form?
Okay, so BRCA mutations exist in a person. They're not, it's not the old voodoo, oh, my great aunt on my father's side had a cancer at age 82, and my great uncle on my mother's side had a prostate cancer at age 81. It's not voodoo. You get tested. The person needs to get tested. So if the person has a mutation, it's only for BRCA1 and 2 and some PALB2 that we know that olaparib is good. We treat the person with a mutation. If her mother has a mutation, but she doesn't, we're not going to treat her. It's the person, it's the lab test, and it's a showing of a mutation. Now, having said that, when people go to the hereditary cancer program, if there's a huge amount of cancer in their family and they're still not found to have a mutation, sometimes the result says, we can't say 100% there's not a mutation. But what they have said is 100% there's not a BRCA1 or 2 mutation, and or a PALB2, and that's what we're treating with olaparib. Does that help?
It does. And I'm going to go back to one of the early slides. Early uh, diagnosis, or is it the type of tumor? Because you could have a small tumor, but the biology, like you say,
Yeah.
you go with the biology. And I agree with you. I always like to understand if a person says, "Oh, I've had breast cancer," what is your biology? That's the first question I always ask. I'm
So,
not a
so you put the two
doctor.
together. So
Yeah,
Kathy, I want to answer a question that's up there on the
sure.
board too. You put the two together. One thing you do, it's a matter of, it's not just a simple formula. It's a matter of putting it together. So if it's and I tried to put that through in one of my slides. If it's a tiny tumor that's low grade ER positive, you wouldn't do anything. So if it's a 9 millimeter tumor, grade 1 ER positive, you might not even give hormones or radiation, but you might give hormones, node negative. But if it's a grade 3 ER negative, HER2 positive tumor, 9 millimeters, in a 40-year-old woman, you might give chemo and Herceptin. So you put the biology and the other together. Just like I said, if it's a low grade in the nodes, you might not give chemo. If it's a high grade, you might. Just one question I want to get that's in the chat. If you don't have breasts, and I didn't get to this, I took this slide out because I didn't think I had time. If you don't have breasts, you don't get mammograms. So anyone who's got breasts gets mammograms. If you don't have breasts and you've got mastectomies, no. But if you developed thickening along your mastectomy site and there was still some breast tissue there, they might decide to do an ultrasound or mammogram or MRI. If you've had reconstruction and you've had your breasts off, so not enhancement, not augmentation, but mastectomies with reconstruction, you don't get mammograms. But if one of your breasts suddenly starts getting bigger or uncomfortable, or you notice a lump, then you would be a candidate for an ultrasound and MRI. So there's asymptomatic and symptomatic. Asymptomatic are people with no symptoms. Follow up, anyone with a prior breast cancer gets mammograms indefinitely if they have breasts. If the mammogram doesn't show everything, then MRIs and ultrasounds are used. No breasts, you've had mastectomies, no regular imaging if you're asymptomatic, but if you develop symptoms, go to your doctor. I hope that's helpful.
So, since we're discussing ER positive recurring much later, and
Potentially, yeah.
yeah, and if you have a young person who you medically induced by chemically induced menopause with the chemotherapies, etc., uh, would and you're still gonna have something in your body that produces estrogen, correct? Even though you're chemically induced. Where are we at with ovarectomies? I know I ask this all the time.
Okay, so and then I actually am going to just follow on with a couple things that are in
Yeah.
the chat that I want to do. So estrogen isn't all bad. I want to say that, we all need estrogen, and estrogen is not all bad. If you've got a tumor that is estrogen receptor positive, the standard treatment is to give a drug, depending on your age and everything, to block that estrogen feeding the tumor. So
Mhm.
that's in premenopausal women, sometimes tamoxifen, more often than not. In postmenopausal women, always almost aromatase inhibitors, but sometimes tamoxifen. Aromatase inhibitors include exemestane, anastrozole, and letrozole. In someone who is premenopausal, there have been studies to show that adding ovarian suppression improves the efficacy of doing endocrine therapy. So it decreases relapse, particularly in persons with higher risk. So somebody who's premenopausal, first of all, can't get an aromatase inhibitor without being menopausal, so you have to make them menopausal. And secondly, even tamoxifen often works better. So if you've got somebody who's premenopausal with a 1 centimeter grade 1 tumor not in nodes, tamoxifen alone might be fine. But if you've got someone who's premenopausal with a 4 centimeter node positive cancer, you might want to give ovarian suppression plus an aromatase inhibitor because it's more effective. So it's again that balancing of how much risk, how much benefit, how much toxicity.
So go to
Ovarian suppression can be given in a variety of ways. It can be given by an injection with either a subcutaneous injection given monthly or 3 monthly, and they're actually equivalent, or with an IM injection given monthly or 3 monthly, or by taking out ovaries. Most of the time, we start with injections because it's a little less drastic. Having said that, if someone's got advanced disease, metastatic disease, and it's going to be injections for a long time, they might want to get out their ovaries so they don't need to get the injections. Getting out your ovaries for that reason is a totally different reason than getting out your ovaries to prevent ovarian cancer. So this is a treatment reason, and the injections are very, very effective. Now, I just want to say one other thing. In the chat, there's a whole bunch of stuff about in situ and invasive. So in situ disease is disease that's in the ducts, and it's often diagnosed by mammograms. Invasive disease, the disease has come out of the ducts. It's the invasive disease that can travel. In situ disease can't travel. In situ disease is almost like a pre-invasive cancer. And lots of people sort of say in situ carcinoma is not even really cancer, but it is. It's cancer cells, but they're in their ducts, but they can't kill you on your own, just be really blunt. They can't spread, they can't go to your liver. If you've got an area of your breast that was taken out that's 5 centimeters of in situ disease, that's called extensive in situ disease, but there's no invasive disease. That cancer doesn't have a risk of coming back around the body, but it might have a higher risk of coming back in the breast. If you've got a 5 centimeter area that was taken out and around it there's a 2 centimeter tumor of invasive and the rest is in situ, then when we're talking about your risk of recurrence for distant disease, it's that 2 centimeter invasive area that we worry about. So I hope that answers the questions that are in the chat because I see there's a lot of comments. So in situ disease is almost like a red flag saying, whoa, you might get invasive disease. Invasive disease is the disease that we worry about traveling.
Okay. Do you have a question that you wanted to pick out of your queue there? Do you have something that you,
Well, there were a few questions around this.
I
When you
thought you
talk about
picked,
size of the tumor,
yeah.
We're also, I have them listed, so we're also, we can get started with sending them,
Okay.
or Kathy can start
Yeah.
reading them, and then we'll
I
probably
can
take care of
start with the
them.
ones that
and there was one about HRT too in the chat. Should I just
Yes,
mention the HRT? Because
sure.
HRT is a conundrum. All of the studies of HRT show that there's a higher risk of getting breast cancer recurrence or breast cancer on HRT. It's highest if you take progesterones and estrogens, but if you have your uterus, you need to take progesterones to decrease your risk of getting uterine cancer. It's lower with just estrogens, it's lower still with nothing. There are some new drugs that are coming along, like Duravi and everything, that people think are safer than others, but we don't have long-term follow-up. Having said that, there's a lot of discussion, and the major thing around discussion is the risk-benefit ratio and how big is the risk really. If somebody has terrible, terrible toxicity side effects with menopause and nothing else helps, then sometimes a short course of HRT makes sense because we're talking about quality of life. But 40 years of HRT probably doesn't make sense because you're going to increase your risk of relapse. If you've just got problems with dry vagina and that, use local estrogens. You don't have to take oral. If you've got trouble with your bones, use bone modifying agents. If you've got trouble with hot flushes, there's some new drugs out there good for hot flushes. But if you've got hot flushes and nothing but HRT helps, then take it for the lowest dose, the shortest period of time. And it's a argument that's been happening for years. I don't know that we're going to get to the bottom of it. I can see it by both a misogynist argument that, oh, women should look young forever and take HRT forever, but we know that it doesn't cause you to look young forever. Or I can see it from a feminist point of view where let's, do what we want with our own bodies. And if you really need to take something, take it, but don't feel bad about taking it. And, I think that, it just has to be an individual decision, but know that all of the studies suggest there is a slight increased risk, including one study that gave HRT to women after a diagnosis of breast cancer that showed a higher risk. Some of the new drugs, elacestrant or Verazio or something, and Duravi, they look a bit safer, but we don't have long-term follow-up.
That clarifies a lot. Good. So I'm going to go to a question. Why is there no additional scan for breast cancer patients after treatment, specifically for those who are high risk and have had a double mastectomy, therefore cannot have a mammogram?
So a mammogram is only good for looking at local recurrence. A mammogram is not going to show anything else. You don't need a mammogram if you have no breast. It's like you don't need a turkey baster if you never make a turkey. I'm sorry to use that as a funny thing, but the equipment is for the activity. The turkey baster is to baste your turkey. The mammogram is to look at breasts. So the mammogram is specifically that. It's a very good question. Why don't people have scans? But the the risk is that each scan gives radiation, and scans aren't perfect. So if you finish your chemo and you're high risk on December 1st, and I do a scan on December 2nd, doesn't show anything. The next year, do you want another one? Or do you want another one in 6 months? Or do you want another one in 3 months? Or do you want another one in 1 month? Or do you want another one in a week? And it gets to be like the most important thing we have to learn is to be comfortable with just being with ourselves. There are blood tests that are coming along. Do not spend money right now on a circulating tumor blood test. They're not validated. But there are blood tests with circulating tumor DNA that are getting better and better and better. And my guess is within the next decade or shorter, for high-risk persons, we'll be doing a circulating tumor DNA after your finished treatment, and maybe at 4 months and 8 months and a year and maybe yearly. And that might tell us about recurrence better than getting exposed to unnecessary radiation with a scan. What is important though is if we have those tests, we have to know we've got ways to treat it that'll make a difference. There's no reason to do a test if it's not going to make a difference. So if we were able to find you had relapsed in a year before a scan showed anything, and we were able to give you a drug that then cured you, that's going to make a difference. So stay tuned, things are going to improve. But the reason to not do a scan is because we don't know how often and we don't want to expose you to unnecessary radiation. If you present 3 months after your treatment with a terrible cough that doesn't want to go away, and it's not like a typical cold cough, yes, maybe then you need a scan. Or if you're in yoga 2 years later and your back starts hurting more than it usually does, then yes, maybe you need a scan. So symptoms should be investigated.
Great. Can I just ask you one question? In terms of treatment or no treatment, you've not mentioned radiation therapy and where.
Okay, I did mention radiation of the breast, and I did mention that radiation is adjuvant. And I did mention that radiation decreases
Oh,
local recurrence. I was here to talk about systemic
yeah.
therapy, I
Okay.
thought, for my
Okay.
invitation.
Yeah.
But
Okay.
radiation is given if you've got your breast on and the tumor is anything other than a very tiny tumor, or if you've got nodes positive to decrease local. And it's adjuvant radiation to decrease local. Treatment of advanced disease is a whole other story.
Okay. Okay. I'm going to go to our next question. What is recommended for screening following breast cancer if you had dense breasts? Why is supplemental screening slash surveillance not being offered for individuals with dense breast tissue following a lumpectomy treatment?
So it should be. Dense breasts has been an indication that you should get mammograms, and if the breast is dense, get ultrasounds as well. Some people are doing mammograms one time and 6 months later, ultrasounds. So there is a recommendation for dense breasts to get ultrasound screening. In some situations, there's a recommendation to get MRI screening. What is coming along are better and better mammograms. Contrast enhanced mammograms are now extremely good at picking up little areas. And when there's more validation of contrast enhanced mammograms, we might not need, first of all, as many MRIs, but maybe not as many ultrasounds as well. So if you've got dense breasts and they remain dense, then they should have extra supplemental screening. And one of the things to remember is density is only seen on mammogram. It's not how your breast looks. So you need to say to your doctor, are my breasts still dense? Density is A, B, C, D. C and D are the dense ones.
Okay. What, I don't know how much time we have for this. What kind of research is being done at this time in determining whether 5 years of AI therapy is optimal, or 10 years, or rest of one's life? And does the taking of a CDK4/6 therapy along with the AI going to affect this determination?
So that's a great question. So first of all, there have been a lot of studies over the last decade of 10 years versus 5 years showing a benefit for 10 years for high-risk people, particularly in decreasing breast coming in the other breast or cancer coming in the other breast. There are also some Scandinavian and European studies of 7 years, so some people are 7 years. There's a very nice calculator, CPS-5 calculator that your doctor can use to determine your risk of relapsing over the second 5 years. And with that calculator can help you make shared decision making on how long you should take it. The question with CDK4/6, nobody knows. So if you take 2 to 3 years of a CDK4/6 inhibitor, you're decreasing your risk of it coming down. They're not easy drugs to take, so they're only really recommended for people who are at high enough risk to take them. If you're at high enough risk and you've taken 2 or 3 years of a CDK and you get to after 5 years of hormone, I think right now that's going to be an individual decision with your oncologist of whether to continue on hormone. We don't have any data now. There is, however, research going on. I think for people who have lots of nodes positive and who have a large tumor and who have tolerated their hormone therapy, it might be worth doing another couple of years.
Okay. So you layered and you identify so many treatments to prevent the metastatic disease in certain, biologies of the tumors, right? And so I know that we face a lot of issues with compliance and people wanting to stay on or just can't stay on. Stacking all these other medications as we learn, how does compliance?
It's hard.
It's hard.
It's hard.
And
There
what would
have been
you say
studies
to?
and studies.
Yeah,
There are studies and studies done of looking at people even taking their blood pressure pills, and it's
yeah.
hard. And I don't envy somebody who's got to take, their ovarian function suppression and their exemestane and their ribociclib and their bisphosphonate and their anti-anxiety pill and everything else. It's really hard. I think that there needs to be a lot of work done with multidisciplinary care, with psychology, social workers, oncologists, nurses, to work together to find strategies. Sometimes with aromatase inhibitors, if you take 2 weeks off, you feel better, and then you can go on it again. So sometimes little drug holidays, and there was a study out of France that worried about drug holidays, but I think sometimes you have to do it. Sometimes you have to decrease dose. So certainly for the CDK4/6 inhibitors, sometimes decreasing dose. I think what we know is some is better than nothing. And for me, the endocrine therapy is the most important. The CDK4/6 inhibitor is second important, not the most. The most important is getting the endocrine through. Some people find that they just need to, go on other medications, sleep medications or what have you to go through it. The CDK4/6 inhibitors can be hard, particularly abemaciclib can be hard with diarrhea, but sometimes people with decreasing doses and with taking Imodium can get through it. Some people prefer the abemaciclib because it's only 2 years, whereas the ribociclib is 3 years. That's a long time. And so to me, I think it's a question of really trying to find strategies that'll help, working around, trying to find things for side effects like hot flushes and diarrhea, trying to relax, trying to realize that it's not forever. The other thing with extended is I always said to my patients for extended, let's not talk about 5 more years, let's go 1 year at a time. Um, I think if people can do it in packages, like, can I get through this year? Can I get through the next year? Can I get through the year after? Bit like a marriage. It's easier than thinking, can I do it forever?
I think what I'm hearing is that don't take it into your own hands. Speak to your doctor before you decide to go off anything.
Definitely.
And that all that they need to know that they could talk to somebody. Unfortunately, we have come to the end of this time. And with this, we could have gone on forever. So I'd like to close by, saying that it conclude. Yes, go ahead.
One thing is, somebody said that there's Ontario has supplemental and BC and Manitoba doesn't. Complain to your oncologist. And you're not in screening, remember. After cancer diagnosis, it's not screening, it's diagnosis and follow-up. And screening, complain for your friends who are in screening. But if you've had a cancer, it's not the screening guidelines. It doesn't end at 76. It doesn't have the same guidelines. Sorry, I just had to put that in.
Yeah, no, it's a diagnostic,
Yeah,
diagnostic It's not screening, and the oncologist should write it as diagnostic. It's not
Yeah.
screening at that point, correct?
Mm-hmm.
Yeah. So we're gonna have to conclude. Like I said, this concludes today's session. Thank you, everyone, for your questions. I know that there was more that we could have gotten to, and I want to thank Dr. Gelman for really a wonderful presentation and so engaging and allowing us to ask all these questions. Fantastic. I want to thank again our sponsors, Novartis, Pfizer, Gilead, Bayer, Tessera, AstraZeneca, and Lilly Canada. Following this session, you will get a link to complete a survey to provide feedback on this session. Please consider leaving feedback as this really helps us improve for future sessions for attendees like yourself. Once the recording is available, Rebecca will share a link along with the resources shared in today's session. And with that, have a wonderful afternoon and thank you, everybody.
Thank you, everyone. Bye-bye.